Hello, today we are going to look at ectopic pregnancy, and you can always follow the information on that YouTube link. Modrik's is my name. And for today, we are going to look at the details about ectopic pregnancy, what it is, the sites that are affected, how we can manage this client, the signs and symptoms. So I request that you follow as we get some information about ectopic pregnancy. So having seen some other topics in the slides as you're following, now we have to look at the word ectopic pregnancy. The word ectopic means out of place. And when you talk about pregnancy, that is the presence of products of conception in someone's uterus. So when I talk about ectopic pregnancy, we are saying is one that grows outside the uterine cavity. Ideally, products of conception should grow in the uterine cavity. When someone's sperm meets the ovum, a zygote is formed, and implantation has to take place in the uterus. But there are incidences where you find implantation has taken place outside the uterine cavity, and this is what we call ectopic pregnancy, where we find products of conception have been implanted outside the uterine cavity. I have said the word ectopic means out of place. So almost always in a fallopian tube, most of this ectopic pregnancy, their common site is the fallopian tube. Although other sites can be made, as you are going to see, ectopic pregnancy can happen in other sites. For example, the ovary, the cervix, the broad ligament, as you're going to see in the next slides. And this is an emergency because failure to act quickly may lead to rupture of the fallopian tube. So these are the normal implantation site that when there is an ovulated egg, this ovum has to be fertilized in the ampulla. And on a 0 day, we shall find a zygote has formed. This has to move out the fallopian tube to take a period of 1 to 4 days. And when it finishes the 4 days, it's supposed to reach the uterine cavity and implantation is going to take place. So as it goes moving towards the uterine cavity, also the ovum keeps on growing, cells keeps on increasing until we shall reach the 7th day, where we have now the fibroblasts implanting in the uterine cavity. And the embryo will now form in the uterine cavity, in the endometrium, and now the fibroblasts are the ones going to impede there, and the growth continues. And this is the normal implantation. But there are instances where we shall find, instead of this embryo moving to be implanted in the uterine cavity, it is implanted elsewhere. And since the tube is one of the sites where the ovum is, most of the time you find the fallopian tube, which we also call oviduct, often being the site of ectopic pregnancy. Some simple pathophysiology about ectopic pregnancy, and we say that as ectopic grows, the placenta infiltrates blood vessels within a fallopian tube, which can cause bleeding within the tube and bleeding into the peritoneal cavity. That as this ectopic pregnancy grows within the tube, it is going to enter into these blood vessels that are in the tube, and it will later now cause bleeding. And eventually this bleeding will be within the tube and also the peritoneal cavity. And we are saying further growth of this ectopic pregnancy, if it is left, then this person is going to have the tube rupture. So that is some brief pathophysiology about ectopic pregnancy. So what are the sites of ectopic pregnancy? The sites, as we are seeing on the projected diagram, we are seeing several sites of ectopic pregnancy. One is the ovary itself. We are looking at the ependybular tube. There is the fallopian tube at the ampulla. We are looking at the ligament, the ischium, the interstitial, then there is the uterine muscle. We look at the cervix, come and talk about the intramural, even the abdomen. Those are some of the sites of ectopic pregnancy, sites which are not the uterine cavity, but you can have the growth of products of conception. The interstitial, the tube, the ampulla, the ependybular, abdomen, ovary, the peritoneal, and we talk about the cervix. Why you are seeing all these kind of pointings, that's the sites identified for ectopic pregnancy. So what are the risk factors for someone to develop ectopic pregnancy? So some of the risk factors are as follows. Since we know that there is no specific cause, we are to look at different things that can lead to ectopic pregnancy, like previous pelvic inflammatory disease, where we have organs in the pelvic region getting inflamed. Some other risk factors is smoking, because it causes vasoconstriction. And if it causes vasoconstriction, it can as well also cause constriction of the fallopian tube. And once the fallopian tube is narrowed, then it can't allow the products of conception to move freely towards the uterus. Another thing is old age. As someone ages, the body tries to lose the muscle tone. As someone ages, the body will be weak. These people have started developing some stenosis in the tube. These people have gotten low hormone level, and you find the products of conception will delay to reach the uterine cavity. Then another risk factor is previous spontaneous miscarriage. People always get miscarriages, eventually develop some scars, which can make the process delayed, and they end up with ectopic pregnancy. Previous medical termination, history of infertility, and previous use of intrauterine contraceptive device. For example, this intrauterine contraceptive device, they are of a barrier, and they can block the products of conception, and they don't reach the uterine cavity, and hence ectopic pregnancy. What are the signs and symptoms of the clinical presentation? We are looking at the first ones, which are in acute phase. One is amenorrhea. That one can spend 6 to 8 weeks. There is abdomen, and that's abscess of messes. There is abdominal pain, and especially on one side of the lower abdomen, and that one will indicate that it's in the fallopian tube, and sometimes it may be on both sides if there is, and that one can be just referred pain. There is uterine bleeding. There is diaphragmatic irritation by blood produced, referred shoulder tip pain. This person will feel as if shoulders are paining, but this is the diaphragmatic irritation. And here the nephrenic nerve is the one affected. We shall look at the signs of shock, abdominal distension, guarding, and rebounce pain. What about in case those signs and symptoms when the problem comes chronic? There is recurrent attacks of vaginal bleeding and abdominal pain, amenorrhea is still there, then this person affected will feel a mass in one fornix. How do we diagnose ectopic pregnancy? One, urine, we shall test for HCG to confirm pregnancy. Blood, we shall do beta HCG still to confirm pregnancy. HCG standing for human chorionic gonadotrophin hormone, which is produced by the placenta, and this confirms that there is products of conception because there's no placenta before fertilization has taken place. We shall do complete blood count, and here we're more interested with the hemoglobin level. Since there is bleeding, this person is likely to be anemic. We shall also do grouping and post-match. This grouping will help us know the group of the patient, and hence can book blood. Then ultrasound scan of the pelvic region, and this one will show us the site where there is implantation. Then we can also do transvaginal scan, and this one is going to show us the products of conception, whether they're in the uterus or they're somewhere else. They can do a small minor surgery, which you call laparoscopy. We use a surgery to check what is in the abdomen. That's how we can diagnose ectopic pregnancy. How do we manage? We are saying this is an emergency. We have those medical intervention and surgical intervention. So how are we going to manage? We are going to offer first aid management. We look at ABCD. We'll ensure airway is fine, there is breathing, there's saturation, and there's no disability. And we are going to manage this complication, ensure this condition to see that there is no complication that occurs. What is that surgical management? One, laparotomy. We are going to operate on the abdomen, and we shall remove these products of conception. We can do salpingectomy, and with this salpingectomy, we are going to incise the fallopian tube and remove the products of conception. Then we can also do salpingotomy. We shall cut off the part of the fallopian tube that has been affected, and we take it off to remove the products of conception. What about the medical management? If it is less than 2 centimeters and the HCG is less than 1,500 international unit, we are going to give methotrexate. This methotrexate is an anti-cancer drug, but you are giving it here because it helps these products of conception to atrophy. And once they atrophy, then they cease to exist. And this is what we want, so that we cannot operate this person. They are going to just disappear by giving methotrexate, which is an anti-cancer drug, but in this case, it will help us get these products of conception atrophy. We can also do laparoscopic visualization, or we operate using an ultrasound scan. Medical management, we shall still continue with intravenous fluids to correct electrolyte imbalance. As we saw, we did CBC. Most times to let us transfuse, because we may find the hemoglobin level is low, and you're going to transfuse this person with whole blood. Then still we are going to give antibiotics for prophylaxis and analgesics because the client has pain. Nursing care, as we end, this is the last slide. With the nursing care, we are going to consent the patient for surgery. We are going to reassure so that we allay anxiety, and we are going to counsel this patient so that we can help him consent and know what is happening. We shall do vital observation like any other patient. Temperature, pulse, respiration, and blood pressure are essential. We are going to put IV line to assess the vein so that in the case we are going to transfuse or give fluids, we have IV line in place. We are going to catheterize. This person is going for a major surgery, salpingectomy, laparotomy. So we need to have a catheter because there is an effect of anesthesia on the urinary system. We are going to rehydrate, and as we rehydrate,